Hello everyone, my name is Hussein Maida Vera and I'm here to discuss or to continue the topic about trauma and stressor-related disorders. For the topic outline, we will discuss the clinical presentation, epidemiology, and comorbidity of both adjustment and prolonged grief disorders, as well as the treatment and etiology of trauma and stressor-related disorders. And also, we will discuss the other specified and unspecified trauma and stressor-related disorders. For the learning objectives, at the end of the report, students should be able to describe the adjustment and prolonged grief disorder present themselves, describe the epidemiology of adjustment disorder and prolonged grief disorder, describe the comorbidity of adjustment disorder and prolonged grief disorder, describe the etiology of trauma and stress-related disorders, describe the different treatments for trauma and stressor-related disorders. First is a clinical presentation. Clinical presentation of adjustment disorder. Adjustment disorder is a development of anxiety or depression in response to stressful but not traumatic life events. Adjustment disorder is the least intense of the three disorders discussed so far in this module or in the module given to us. An adjustment disorder occurs following an identifiable stressor that happened within the past 3 months. This stressor can be single event like loss of job or death of a family member, and it can be a series of multiple stressors such as cancer treatment, divorce, or a child custody issues. Contrary to PTSD and acute stress disorder, adjustment disorder does not have a set of specific symptoms an individual must meet for diagnosis. Adjustment disorder does not have a predetermined set of symptoms that a person must exhibit in order to be diagnosed. Instead, whatever symptoms the person is going through need to be connected to the stressor, severe enough to affect social, occupational, or other key areas of functioning and create marked discomfort or that is out of proportion to the severity or intensity of the stressor according to APA 2022. It should be noted that there are modifiers associated with adjustment disorder. Due to the variety of behavioral and emotional symptoms that can be present with an adjustment disorder, clinicians are expected to classify a patient's adjustment disorder as one of the following. First is a with depressed mode, with symptoms mainly of low mood, tearfulness, or feelings of hopelessness. Second is with anxiety, with mainly symptoms of nervousness, worry, jitteriness, or separation anxiety. Third is the with mixed anxiety and depressed mood, with symptoms of the combination of depression, and anxiety. Fourth is with disturbance of conduct, which is mainly happening or predominantly happening. Next is with mixed disturbance of emotions and conduct, with both emotional symptoms such as depression, anxiety, and a disturbance of conduct are also predominant or unspecified if the behaviors do not meet criteria for one of the aforementioned categories. Based on the individual's presenting symptoms, the clinician will determine which category best classifies the patient's condition. These modifiers are also important when choosing treatment options for patients. These modifiers are also the types of adjustment disorders. Take note of that. For the diagnosis of adjustment disorders, the DSM-V TR lists these criteria. Its diagnostic Criterion A, the development of emotional or behavioral symptoms in response to an identifiable stressor occurring with 3 months of the onset of the stressor. B is these symptoms or behaviors are clinically significant as evidenced by one or both of the following, which is marked distress that is out of proportion to the severity or intensity of the stressor, taking into account the external context and the cultural factors that might influence symptom severity and presentation. And the second is significant impairment in social, occupational, or other important areas of functioning. Criterion C says the stress-related disturbance does not meet the criteria for another mental disorder and is not merely an exacerbation of a pre-existing mental disorder. Criterion D says the symptoms do not represent normal bereavement and are not better explained by prolonged grief disorder. E is that once the stressor or its consequences have terminated, the symptoms do not persist for more than an additional 6 months. The present are the it features that the presence of emotional or behavioral symptoms in response to an identified stressor, excuse me, is the essential feature of adjustment disorder, which says in the criterion A. The stressor may be a single event or a termination of a romantic relationship, or there may be multiple stressors. Example like marked business difficulties and marital problems. Stressors may be recurrent, like associated with seasonal business crisis, unfulfilling sexual relationship, or continuous, like a persistent painful illness with increasing disability living in a crime-hidden neighborhood. Stressor may affect a single individual, an entire family, or a larger group or community, like in a natural disaster. Some stressors may accompany specific development events like going to school, leaving a parental home, re-entering a parental home, getting married, become a parent, failing to attain occupational goals, or retirement. Adjustment disorder may be diagnosed following the death of a loved one when the intensity, quality, or persistence of grief reactions exceeds what normally might be expected when cultural, religious, or age-appropriate norms are taken into account and the grief reaction does not meet criteria for prolonged grief disorder. For the length, for the length, for the length of symptoms, the duration of the symptoms of an adjustment disorder can be indicated by using the acute or persistent or chronic specifiers. Acute or this specifier can be used to indicate persistence of symptoms for less than 6 months. It cannot exceed more than 6 months. Wherein persistent or chronic specifier, this specifier can be used to indicate persistence of symptoms for 6 months or longer. By definition, symptoms cannot persist for more than 6 months after the termination of the stressor or its consequences. The persistent specifier therefore applies when the duration of the disturbance is longer than 6 months in response to a chronic stressor or to a stressor that has enduring consequences. Next is the clinical presentation of prolonged grief disorder. Prolonged grief disorder is defined as an intense yearning or longing or preoccupation with thoughts or memories of the deceased who died at least 12 months ago. The DSM-V included a condition for further study called persistent complex bereavement disorder. In 2018, a proposal was submitted to include this category in the main text of manual and after careful review of the literature and approval of the criteria. It was accepted in the second half of 2019 and added as a new diagnostic entity called prolonged grief disorder. The individual will present with at least 3 symptoms to include feeling as though part of oneself has died, disbelief about the death, emotional numbness, feeling that life is meaningless, intense loneliness, problems engaging with friends or pursuing interests, intense emotional pain, and avoiding reminders that the person has died. People who suffer from prolonged grief disorder frequently have unhelpful beliefs about who they are, feel guilty for the deceased, and have pessimistic attitudes toward their future prospects. There are also reports of harmful health habits through brought on by a lack of self-care and concern. Additionally, they could have hallucinations of the deceased, feel bitter and furious, be restless, blame others for the death, and have poorer quality and less sleep according to APA 2022. For the diagnosis of prolonged grief disorders, the DSM-5 TR lists these criteria for the diagnostic criteria. A. The death at least 12 months ago of a person who was close to bereaved individual, or for children and adolescents at least 6 months ago. B. Since the death, the development of persistent grief response characterized by one or both of the following symptoms, which have been present most days to a clinically significant degree. In addition, the symptoms or symptom has occurred nearly every day for at least the last month, which is the intense yearning or longing for the deceased person and preoccupation with thoughts or memories of the deceased person, or in children and adolescents, preoccupation may focus on the circumstances of the dead. C. Since the death, at least 3 of the following symptoms have been present most days to a clinically significant degree. In addition, the symptoms have occurred nearly every day for at least the last month, like identity disruption or feeling as though part of oneself has died since the death, marked sense of disbelief about the death, avoidance of reminders that the person is dead. In children or in adolescents may be characterized by efforts to avoid reminders. The intense emotional pain like anger, bitterness, and sorrow related to the death, or the difficulty reintegrating into one's relationship and activities after the death, for example, problems engaging with friends, pursuing interest, or planning for the future. Yeah, like that. Planning for the future. 6 is the emotional numbness or absence or marked reduction of emotional experience as a result of the death. 7 is the feeling that life is meaningless as a result of the death. And lastly, in the intense loneliness as a result of the death. D. The disturbance caused clinically significant distress or impairment in social, occupational, or other important areas of functioning. E. The duration and severity of the bereavement reaction clearly exceed expected social, cultural, or religious norms for the individual's culture and context. F. The symptoms are not better explained by another mental disorder, such as major depressive disorder or post-traumatic stress disorder, and are not attributable to the physiological effects of a substance like medication and alcohol or another medical conditions. The diagnostic features says prolonged grief disorder represents a prolonged maladaptive grief reaction that can be diagnosed only after at least 12 months or 6 months in children and adolescents. Who have elapsed since the death of someone with whom the bereaved had a close relationship in the said criterion A earlier. Although in general, this time frame reliably discriminates normal grief from grief that continues to be severe and impairing. The duration of adaptive grief may vary individually and cross-culturally. The condition involves the development of a persistent grief response characterized by intense yearning or longing for the deceased person, or often with intense sorrow and frequent crying or preoccupation with thoughts or memories of the deceased. Although in children and adolescents, this preoccupation may focus on the circumstances of the death. The intense yearning or longing or the preoccupation has been present most days to a clinically significant degree and has occurred nearly every day for at least the last month in the said criterion B. Moreover, since the death, at least three additional symptoms have been present most days to a clinically significant degree and have occurred nearly every day for at least the past month. These symptoms include identity disruption since the death, or feelings as though part of oneself has died, said in Criteria 1 also. A marked sense of disbelief about the death, said in Criterion C, the second symptoms, avoidance of reminders that a person is dead, with which in children and adolescents may be characterized by efforts to avoid reminders. Intense emotional pain, or the anger, bitterness, guilt since the death, having difficulty reintegrating into personal relationships and activities since the death, emotional numbness, are as a result of the death, feeling that life is meaningless as a result of the death, or intense loneliness as a consequence of death, all said in the criterion C. These symptoms of prolonged grief disorder must result in clinically significant distress or impairment in social, occupational, or other important areas or functioning in the bereaved individual, said earlier in Criterion D. The nature, duration, and severity of the bereavement reaction must clearly exceed expected social, cultural, or religious norms of the individual's culture and context, said in Criterion E. Although there are variations in how grief can manifest, the symptoms of prolonged grief disorder occurs across genders and in diverse social and cultural groups. Now we will we will tackle the epidemiology of adjustment disorder. Adjustment disorders are relatively common as they describe individuals who are having difficulty adjusting to life after a significant stressor. In psychiatric hospitals in the US, Australia, Canada, and Israel, adjustment disorders accounted for roughly 50% of the admissions in the 1990s. It is estimated that anywhere from 5 to 20% of individuals in outpatient mental health treatment facilities have an adjustment disorder as their principal diagnosis. Adjustment disorder has been found to be higher in women than men. The epidemiology of prolonged grief disorder. As this is a new disorder, the prevalence of DSM-5 prolonged grief disorder is currently unknown. Using a different definition of the disorder, a meta-analysis of studies across 4 continents suggests a pooled prevalence of 9.8%. It should be noted that these studies could not only be loosely compared with one another, making the reported prevalence rate questionable. Populations with elevated exposure to trauma may have higher prevalence rates. Mean prevalence of prolonged grief presentations may be higher in high-income Western countries than in high and upper middle-income Asian countries, but recent studies in China have revealed higher rates and substantial variation. Prevalence of persistent complex bereavement disorder, included in DSM-5 Section 3, conditions for further study, among bereaved U.S. youth in the community was estimated at 18%. For their comorbidity. The comorbidity of adjustment disorder. Unlike most of the disorders we have reviewed thus far, or mentioned at the previous reports, adjustment disorders have high comorbidity rate with various other medical conditions, according to APA 2022. Often following a critical or terminal medical diagnosis, an individual will meet the criteria for adjustment disorder as they process the news about their health and the impact their new medical diagnosis will have on their life. Other psychological disorders are also diagnosed with adjustment disorder. However, symptoms of adjustment disorders must be met independently of the other psychological conditions. For example, an individual with adjustment disorder with depressive mood must not meet the criteria for a major depressive episode. Otherwise, the diagnosis of MDD or major depressive disorder should be made over adjustment disorder. As the DSM-V TR says, adjustment disorders are common accompaniments of medical illness and may be the major psychological response to a medical condition according to APA 2022. For the comorbidity of prolonged grief disorder, prolonged grief disorder is commonly comorbid with major depressive disorder or MDD, post-traumatic stress disorder or the PTSD if the death occurred in violent or accidental circumstances, or substance use disorders and separation anxiety disorders. The most common comorbid disorder with symptoms of prolonged grief disorder are major depressive disorder, PTSD, and substance use disorders. PTSD is more frequently comorbid with prolonged grief disorder symptoms when the death occurred in violent or accidental circumstances. Separation anxiety disorder involving major living attachment figures may be comorbid with symptoms of prolonged grief disorders. Now, we will identify or we will discuss the different treatments of trauma and stressor-related disorders. The first treatment is the psychological debriefing. Psychological debriefing, I'm sorry. Thorough psychological debriefing is one technique to prevent the onset of PTSD symptoms. A form of crisis intervention known as psychological debriefing compels people who have just gone through a traumatic event to talk about or process their feelings in relation to that event, usually within 72 hours of the event, as said in the table, the slide. A psychological debriefing can be conducted in a variety of ways, but they all generally follow the same structure, such as identifying the facts or to answer the questions like what happened, then evaluating the individual's thoughts and emotional reaction to the events, leading up to the event, during the event, and then immediately following, then normalizing the individual's reaction to the event, then discussing how to cope with these thoughts and feelings, as well as creating a designated social support system. The effectiveness of psychological debriefing has been a topic of discussion throughout the past few decades. Those who have worked in the field contend that psychological debriefing isn't a way to treat or prevent PTSD, but rather a way to help people recover from traumatic events more quickly. Research consistently indicates that psychological debriefing is ineffective in reducing post-traumatic symptoms or speeding up recovery for people with PTSD after traumatic experience such natural disasters, burns, or war. One theory says that these early efforts can motivate patients to dwell on their symptoms or the actual event, which would maintain PTSD symptoms. There has been a significant drive to increase structure and training for professionals using psychological debriefing in an effort to fight these unfavorable findings of psychological debriefing, ensuring that those offering treatment are appropriately qualified to do so. Next treatment is the exposure therapy. Although exposure treatment is typically used to treat anxiety disorders, it has also demonstrated excellent success in treating PTSD-related symptoms by assisting patients in overcoming concerns connected to the traumatic experience. The imaginal, in vivo, and flooding exposure procedures are some of the most popular types of exposure techniques. Let me discuss to you the three exposure procedures. First is in imaginal exposure, or the individual mentally recreates specific details of the traumatic event. The patient is then asked to repeatedly discuss the event in increasing detail, providing more information regarding their thoughts and feelings at each step of the event. It's like doing therapy from easy to hard part or sessions. During in vivo exposure, the individual is reminded of the traumatic event through the use of videos, images, or other tangible objects related to the traumatic event that induces a heightened arousal response. While the patient is re-experiencing cognitions, emotions, and physiological symptoms related to the traumatic experience, they are encouraged to utilize positive coping strategies such as relaxation techniques to reduce their overall level of anxiety. The imaginal exposure and in vivo exposure are generally done in a gradual process, with imaginal exposure beginning with fewer details of the events and slowly gaining information over time. In vivo starts with images or videos that elicit lower levels of anxiety, and then the patient slowly works their way up a fear hierarchy until they are able to be exposed to the most distressing images. Another type of exposure therapy is the flooding, which involves disregard for the fear hierarchy. Another type of presenting the most distressing memories or images at the beginning of the treatment. It means that um, it is not showing a gradual process. It is what it is. What you see ay what you want to talk or what you want to see. It is what it is. It don't matter if it is easy or for you it is for you or hard. Well, some argue that this is a more effective method. It is also the most distressing and place patients at risk for dropping out of treatment because it doesn't have a gradual process. It is what it is. The next treatment is the cognitive behavioral therapy or CBT. Cognitive behavioral therapy, as discussed in the mood disorders chapter, has been proven to be an effective form of treatment for trauma stress-related disorders. It is believed that this type of treatment is effective in reducing trauma-related symptoms, excuse me, due to its ability to identify and challenge the negative cognitions surrounding the traumatic event and replace them with positive and a more adaptive cognitions. Trauma-focused cognitive behavioral therapy or TFCBT is an adaptation of CBT that utilizes both CBT techniques, excuse me, and trauma-sensitive principles to address the trauma-related symptoms. According to the Child Welfare Information Gateway, TFCBT can be summarized via the acronym PRACTICE. So take note of this acronym PRACTICE as I'm going to discuss what it is. P in the word practice stands for psychoeducation about the traumatic event. This includes discussion about the event itself as well as typical emotional and or behavioral responses to the event. R stands for relaxation training, teaching the patient how to engage in various types of relaxation techniques such as deep breathing and progressive muscle relaxation. A stands for affect, discussing ways for the patient to effectively express their emotions, fears related to the traumatic event. C stands for correcting negative or maladaptive thoughts. T is for trauma narrative. This involves having the patient Relieve the traumatic event verbally or written, including as many specific details as possible. I is for in vivo exposure, as mentioned earlier, for by using of images and videos. C is co-joint family session. This provides the patient with strong social support and a sense of security. It also allows family members to learn about the treatment so that they are able to assist the patient if necessary. And lastly, the E, enhancing security. Patients are encouraged to practice the coping strategies they learn in TFCBT to prepare for when they experience these triggers out in the real world, as well as any future challenges that may come their way. Next is the eye movement desensitization and reprocessing, or EMDR. In the late 1980s, psychologist Francine Shapiro found that by focusing her eyes on the waving leaves during her daily walk, her troubling thoughts resolved on their own. From this observation, she concluded that lateral eye movements facilitate the cognitive processing of traumatic thoughts. While EMDR has evolved somewhat since Shapiro's first claims, the basic components of EMDR consist of lateral eye movement induced by the therapist moving their index finger back and forth approximately 35 centimeter from the client's face, as well as components of cognitive behavioral therapy and exposure therapy. There are following 8 steps approach that are standard treatment approach of EMDR. First, approach is the patient history and treatment planning. It identifies trauma symptoms and potential barriers to treatment. Second is the preparation or the psychoeducation of trauma and treatment. Third is the assessment or careful and detailed evaluation of the traumatic event. Patient identifies images, cognitions, and emotions related to the traumatic event, as well as trauma-related physiological symptoms. The fourth approach is desensitization and reprocessing. It holds the trauma images, cognition, and emotions in mind while simultaneously assessing their psychological symptoms. The patient must track the clinician's finger movement for approximately 20 seconds. At this time, the patient must blank it out and let go of the memory. Next is the installation of positive cognitions. Once the negative image, cognition, and emotions are reduced, the patient must hold onto a positive image or thought while again tracking the clinician's finger movement for approximately 20 seconds. Next is the body scan. Patient must identify any lingering bodily sensations while again tracking the clinician's fingers for a third time to disregard any remaining trauma symptoms. Next is the closure. Patient is provided with positive coping strategies and relaxation techniques to assist with any recurrent cognitions or emotions related to the traumatic experience. Lastly, the eighth approach, the reevaluation. Clinicians assess if treatment goals were met. If not, schedules another treatment session and identifies remaining symptoms. As mentioned earlier, only steps 4 and 6 are specific to AMDR. The remaining treatment is essentially a combination of exposure therapy and cognitive behavioral techniques. Because of the high overlap between treatment techniques, there have been quite a few studies comparing the treatment efficacy of EMDR to TF-CBT and exposure therapy. While research initially failed to identify a superior treatment, often citing EMDR and TF-CBT as equally efficacious in treating PTSD symptoms, more recent studies have found that EMDR may be superior to that of TF-CBT, particularly in psycho-oncology patients. While meta-analytic studies continues to debate which treatment is the most effective in treating PTSD symptoms, the World Health Organization's publication on the guidelines for the management of conditions specifically related to stress identified TF-CBT and EMDR as the only recommended treatment for individuals with PTSD. The last two treatments of trauma and stressor-related disorders are pharmacological treatment and psychotherapy. So let's discuss the pharma, psychopharmacological treatment. Most clinicians concur that resolution of symptoms cannot be achieved without implementing exposure and or cognitive techniques that target the physiological and maladjusted thoughts maintaining the trauma symptoms, even though psychopharmacological interventions have been shown to provide some relief, especially to veterans with PTSD. Having said that, experts concur that interventions in psychopharmacology are an effective second line of treatment, particularly when psychotherapy alone is ineffective at relieving symptoms. Among the most common types of medication used to treat PTSD symptoms are selective serotonin reuptake inhibitors, or the SSRI. As previously discussed in the depression chapter, SSRIs work by increasing the amount of serotonin available to neurotransmitters. Tricyclic antidepressants, or the TCAs, and monoamine oxidase inhibitors, or the MAOIs, are also recommended as second-line treatments. Their effectiveness is most often observed in individuals who report co-occurring major depressive disorder symptoms, as well as those who do not respond to SSRIs. Unfortunately, due to the effective CBT and EMDR treatment options, research on psychopharmacological interventions has been limited. Future studies exploring other medication options are needed to determine if there are alternative medications option for stress and trauma disorder patients. Lastly, the psychotherapy. For adjustment disorder, this is beneficial for many persons with adjustment issues. Excuse me. And they frequently only require brief therapy. Longer treatment may be beneficial for other people, especially those with enduring adjustment issues or continuing stressors. Psychotherapy, medicines, or a combination of the two are used to treat adjustment disorder. Psychotherapy, also called talk therapy, is the main treatment for adjustment disorders. This can be provided as individual, group, or family therapy. This therapy can provide emotional support, help you get back to your normal routine, help you learn why the stressful event affected you so much, and can help you learn stress management and coping skills to deal with stressful events. For prolonged grief disorder or complicated grief is often treated with a type of psychotherapy called complicated grief therapy. It's similar to psychotherapy techniques used for depression and PTSD, but it's specifically for complicated grief. This treatment can be effective when done individually or in a group format. During therapy, you may learn about complicated grief and how it's treated. Explore such topics as grief reactions, complicated grief symptoms, adjusting to your loss, and redefining your life goals. Hold imagined conversation with your loved one and retell the circumstances of the death to help you become less distressed by images and thoughts of your loved one. Explore and process thoughts and emotions, improving coping skills, reduce feelings of blame and guilt. For the next topic, the etiology of trauma and stressor-related disorders. There are four causes of trauma and stress-related disorders, or their origins. First is the biological. HPA axis, one theory for the development of trauma and stress-related disorder, is the over-involvement of the hypothalamic pituitary adrenal, or the HPA axis. The HPA axis is involved in the fear-producing response, and some speculate that dysfunction within this axis is to blame for the development of trauma symptoms. Within the brain, The amygdala serves as the integrative system that inherently elicits the physiological response to a traumatic or a stressful environmental situation. The amygdala sends this response to the HPA axis to prepare the body for fight or flight. The HPA axis then releases hormones like epinephrine and cortisol to help the body to prepare to respond to a dangerous situation. While epinephrine is known to respond to is known to cause physiological symptoms such as increased pressure, increased heart rate, increased alertness, and increased muscle tensions. To name a few, cortisol is responsible for returning the body to homeostasis once the dangerous situations is resolved. Researchers have studied the amygdala and HPA axis in individuals with PTSD and have identified heightened amygdala reactivity in stressful situations, as well as the excessive responsiveness to stimuli that is related to one specific traumatic event. Additionally, students have indicated that individuals with PTSD also show a diminished fear extinction, suggesting an overall higher level of stress during non-stressful times. These findings may explain why individuals with PTSD experience an increased startle response and exaggerated sensitivity to stimuli associated with their trauma. Next is their cognitive. An individual may be more likely to acquire PTSD or other stress disorders if they already have depression or anxiety. According to one explanation or theory, these people would dwell on or overthink the traumatic experience, which would draw attention to it and make it more likely that stress-related symptoms would arise. Additionally, PTSD symptoms may also be influenced by negative cognitive patterns or poorly adjusted ideas about oneself and the surroundings. For instance, people who perceive life events as out of their control exhibit more severe signs of stress than others who believe they have some degree of control over their lives. Next is the social. This may be true for many psychological problems. However, social and familiar support have been found to be protective factors for those who are prone to developing PTSD. More precisely, rape victims report fewer trauma symptoms and quicker psychological recovery when they are loved and cared for by their friends and family members, as opposed to being condemned for their behavior before the rape. Last for the etiology is the socio-cultural. As was previously said, PTSD is reported to be more common in some ethnic groups than others. While there is evidence to show that cultural groups process traumatic events differently and may consequently be more susceptible to the condition, this may be due to higher exposure to traumatic events. The prevalence of PTSD has frequently been linked to the cultural group of Hispanic Americans. Hispanic Americans are the cultural group that experiences the most traumatic symptoms, according to studies on everything from duty police officer stress to combat to stress from natural disaster. Combat related PTSD to stress from natural disasters. Sorry. Additionally, compared to men, women report more PTSD symptoms. Stigmas connected with receiving psychiatric treatment as well as a higher chance of exposure to stressful events linked to PTSD are a few possibilities for this differential. Studies examining rates of PTSD symptoms in former members of the armed forces and law enforcement haven't found any evidence of a substantial gender difference in PTSD diagnosis rates, indicating that PTSD rates for men and women in these situations are similar. Let's talk about the other specified trauma and stress-related disorder. This category applies to presentations in which symptoms characteristics of a trauma and stress-related disorder that cause clinically significant distress or impairment in social, occupational, or other important areas of functioning predominate but do not meet the full criteria for any of the disorders in the trauma and stress-related disorders in diagnostic class. The other specified trauma and stressor-related disorder category is used in situations in which the clinician choose to communicate the specific reason that the presentation does not meet the criteria for any specific trauma and stressor-related disorder. This is done by recording other specified trauma and stressor-related disorder followed by the specific reason, like persistent response to trauma with PTSD-like symptoms. Examples of presentations that can be specified using the other specified designation include the following. First is the adjustment-like disorders with delayed onset of symptoms that occur more than 3 months after the stressor. Second is the adjustment-like disorders with prolonged duration of more than 6 months without prolonged duration of stressor. Third is the persistent response to trauma with PTSD-like symptoms, like symptoms occurring in response to a traumatic event that falls short of the diagnostic threshold of PTSD and that persists for longer than 6 months, sometimes referred to as subthreshold partial PTSD. Fourth is the attack de nervios, or the attack of nerves in English. And lastly, the other cultural syndromes. Last of the topic is the unspecified trauma and stress-related disorder. This category applies to presentations in which symptoms characteristic of a trauma and stressor-related disorder that can cause clinically significant distress or impairment in social, occupational, or other important areas of functioning predominate but do not meet the full criteria for any of the disorders in the trauma and stressor-related disorders diagnostic class. When there is insufficient data to determine a precise diagnosis, the illness associated to trauma and stressors may be diagnosed as an unspecified trauma and stressor-related disorder. It can be used to characterize signs of linked trauma disorders that result in distress and impairment but do not fully fit the diagnostic criteria. And that ends my report. Thank you for listening, and I hope that you have noted all the important details that I've mentioned earlier. Thank you. And these are my references. Thank you.